Hello everyone, welcome to HIM 216. This is your second lecture for Chapter 8. We're on page 143 in your textbook. And we're beginning at the section that talks about closed procedures and then closed procedures that are converted to open procedures. Laparoscopic procedures are very available today. They're a great thing because they are less invasive. Patients usually have fewer complications. They heal much more quickly, so they are widely used. When we're talking about using a scope, there are laparoscopic procedures, and these are procedures that are performed in the abdomen, like a laparoscopic cholecystectomy, a laparoscopic appendectomy. Then we have the thoracoscopic approach, and this is the thorax, it's the chest, and then the arthroscopic approach, and this is the joint. These are percutaneous endoscopic procedures. So let's go to appendectomy in the index. And you can see there's a code for excision and one for resection. I have never seen an appendectomy where they did not remove the entire appendix, meaning that it would be a resection and not an excision. So when we go to the table, we look under approach, and you can see that these are our options for the approach. Open. Percutaneous is not an option here. It can be percutaneous endoscopic, and then the via natural or artificial openings. Typically, it is a percutaneous endoscopic procedure, or it is an open procedure, one or the other. And again, if you click on the question mark here, it is going to define those approaches for you so that that can help you out. Let's look at a cholecystectomy. Now, again, when we're taking out the gallbladder, it could be an excision, meaning partial, but I really never see that. What I see is the whole gallbladder comes out. It's a resection. And then it can either be open or it can be percutaneous endoscopic. Those are your only choices here. And typically it's percutaneous endoscopic. However, there are times when they will attempt to do an endoscopic, we call it a lap chole, laparoscopic cholecystectomy, when they will attempt to do a lap chole, and for whatever reason they end up having to convert it to an open. If the gallbladder is very inflamed, or if there is a lot going on in that abdomen, they may want to open it up instead of trying to do it with a lap chole. When that happens, when we have a laparoscopic or an endoscopic procedure that is converted to an open, we have to have two codes. We have to have one for the attempted endoscopic procedure and then one for the open procedure. So let's say that we had a lap chole that was converted to an open. This would be our code. The only difference is between the lap chole and the open chole is the approach. But what we would be doing is we would be coding an inspection of the gallbladder. And that would take us to OFJ4. And so when we're coding these aborted endoscopic procedures, we code it as far as it went. And of course, if they were trying to do a lap chole and they converted it to an open, that approach would be percutaneous endoscopic, because that's what they were doing when they had to abort it. So this is certainly a note card option. If you have a closed converted to an open, takes two codes. The first code is usually the inspection code. That inspection is not the definitive procedure. It is not the first listed procedure. It's not the principal procedure. It's a secondary procedure. And the definitive open procedure would be the principal procedure. Now, the other thing that we can code is the reason for the canceled, closed converted to open procedure. And these are in category Z53, procedure converted to open procedure. So let's see. So if in the index, if I go to procedure converted, and you can see it has arthroscopic to open, laparoscopic to open, thoracoscopic to open, and these are all in this category of Z53.3. And so you would also want to add that. You can see we have a little Medicare code editor note here in the tabular, and it tells us that that Z code is an unacceptable principal diagnosis. So let's look on page 144. If you will look at this first example, this patient came in for a colon resection because they have cancer of the descending colon. And so they made an incision in the abdomen. They went down through the subcutaneous tissue and the fascia. But then the patient became unstable. They went into atrial fib. And so they decided to stop that procedure for the time being. So they closed the incision before they were able to accomplish the colon resection. So they can't actually code a colon resection because they didn't take out the colon. So what we actually have to do here is code this procedure as far as it went. And so in this example, this is in fact going to be an inspection of the root operation is inspection, subcutaneous tissue and fascia. And this is going to take us we're going to trunk OJJT, and this approach was open, and there's no device and no qualifier. If I wanted to use the table for this, I could choose medical surgical, and then I could go to skin and subcutaneous tissue, and then I could choose inspection, and then I would choose the subcutaneous tissue of the trunk, open, no device, and no qualifier. So we can only code the procedure as far as it goes. Now there are times when procedures are canceled, and there are many reasons that a procedure may be canceled. And if we go back into the diagnosis tab and we go to Z53, and then in the index, if we go to canceled, we'll see canceled procedure because of. And when we look at these codes, Z53.2, Z53.0, procedure not carried out because of contraindication. And you can see that one of these is due to patient smoking, other contraindication. Not carried out because of patient's decision of a belief or peer pressure, group peer pressure. Z53.2, not carried out because of the patient's decision or other unspecified reason. So the patient just changes their mind. They decide they don't want to have the procedure. Maybe they're afraid, or maybe it's a sterilization and they don't want to have it done. Z53.21, patient left AMA. They left before they were seen by the provider, so nobody really knows why they left. And then .29, not carried out because of other reason. So when you have a procedure that is canceled, if it was scheduled and the patient never showed up, you don't have a chart, you don't have anything to code, that becomes irrelevant. You may have pre-op lab work. If you do, you're going to have an account number for that, and you're just simply going to code that based on the reason that the patient was coming in. if there was a complication and the procedure was canceled because of the complication would be a secondary diagnosis. But the principal diagnosis would not change. The condition determined to have occasioned the admission. So if the patient was coming in for sterilization, there actually is a code for desirous sterilization. That would still be the principal diagnosis code. If the patient was coming in for cataract removal, they had cataracts and for some reason the procedure wasn't done, the principal diagnosis would still be the fact that they have cataracts. So let's look at these examples on the bottom of page 144. The patient was admitted for hysterectomy because of uterine fibroids. So what is our diagnosis there? Our diagnosis is not hysterectomy. That is the procedure. Our diagnosis is the uterine fibroids. Let's see if we put in fibroid here. Fibroid of the uterus D25.9. And if I put in leiomyoma, uterus, a uterine fibroid is a leiomyoma. And when you put in leiomyoma and uterus, then you have more specific codes for the specific type of fibroid it is. You may find this, the surgeon may document this, or you may find this in the path report. So I want you to be aware that looking up the actual term leiomyoma as opposed to fibroid will lead you to more specific codes. So in this case, after the patient came in, she told the nurse that she was having second thoughts and she had decided not to have that surgery, so she was discharged. So the only information we have is that she had a fibroid, so that code is D25.9. We absolutely cannot code the hysterectomy because she did not have it. And then this code Z53.29, that is a canceled procedure, and we'll go to those categories. And the patient just changed her mind. Your book has the code Z53.29, procedure not carried out because of patient's decision for other reason, and canceled because of patient's decision, specified reason NEC. Anyway, so that would be an example of a canceled procedure. And the next one, the patient was admitted for coronary artery bypass grafting because of coronary atherosclerosis of the native arteries. So this diagnosis code, this principal diagnosis is coronary atherosclerosis of the native arteries. The procedure that was planned was a CABG, coronary artery bypass grafting, but the physician became ill, so they had to reschedule the surgery. So if we code the arteriosclerosis, and this is coronary, coronary artery I-25.10. That is our principal diagnosis code. That doesn't change simply because we had to cancel the surgery. And then, of course, when we go to canceled because of, and then specified reason NEC, Z53.8, when we go to this category, and we look at our options for reasons that it was not carried out, there wasn't a contraindication, it wasn't anything to do with the patient, it was actually another reason, which was, of course, that the physician became ill. So in this final example, patient came in for a lap chole. They had cholelithiasis of the gallbladder, so that is gallstones. That cholelithiasis is the principal diagnosis. The patient was having an acute exacerbation of COPD, so they treated the patient with steroids and a nebulizer, and the patient was discharged, and they rescheduled that surgery, so the patient did not have surgery. So our principal diagnosis code is the cholelithiasis, K80.20. We are going to code the acute exacerbation of COPD. That was the complication, Z44.1. And then this is a contraindication. The exacerbation of the COPD was a contraindication for this procedure, and so that is Z53.09. Now I want you to look at the top of page 145. And this talks about biopsy procedures. And there are several ways that a biopsy can be obtained. A biopsy is diagnostic. They are sending a sample of the specimen to pathology to be evaluated. And they can do it through excision, which means they cut off a part of the body part. Extraction, which means they pull or strip the body part using force. Or drainage, when they take out fluid or gases from a body. Of note, I want you to notice this. Sometimes a surgeon will remove the entire specimen and call it a biopsy, but when the entire specimen, such as a breast lump or a colon polyp, is removed, this is therapeutic and it is not assigned a biopsy code. So depending on what procedure is being done, it could be an excision or a resection, and the qualifier is Z, not X. If we have a biopsy that is followed by more definitive treatment, both the biopsy and the definitive treatment code are assigned. And the classic example of this is a patient that has a breast mass. They come in and they do an excision, a biopsy of that mass, send it to pathology. The pathologist confirms that it is breast cancer, and so they do a mastectomy. And a lot of times they'll have a patient sign the consent for the mastectomy before they even start the procedure, so they don't even wake the patient up and tell them that they have breast cancer. They just perform the biopsy and then follow it up with the mastectomy. When we're talking about lymph node excisions, many times when malignant neoplasms are being removed, surrounding lymph nodes will be removed so that they can determine whether or not the malignancy has spread into the lymph nodes, which then of course means it goes through the entire body. And if the intent's to remove all the lymph nodes in that area, then it's a resection, because they're taking out all those lymph nodes. If they take out a lymph node chain, it's a resection. But if they're just taking out a few lymph nodes, then it's an excision. Your book tells you that the lymph nodes can be described by the level where they're located, and each level is considered a chain. So if they tell you that they took out an entire level of lymph nodes, that's a chain, and that would be a resection. And then the sentinel lymph node is the first lymph node to which the cancer cells are most likely to spread. And so if they may tell you that they did a sentinel node lymph biopsy, that prevents them from having to take out all the lymph nodes, they'll just do a sentinel node. If it's negative, then typically they won't take out all the rest of those lymph nodes. So let's look at this example on the bottom of page 145. The patient's coming in with a breast mass. It's in the right upper quadrant. They had an open biopsy with immediate total mastectomy and removal of sentinel lymph nodes. Pathology showed that they had carcinoma. The nodes were negative for the malignancy. So when we're looking at the codes for these, the principal procedure for this is going to be the actual mastectomy. That is the definitive procedure. So if we go to mastectomy, you see we have an option excision or resection, and we're choosing the resection because it was a total mastectomy. And this was a total mastectomy of the right breast. So we're choosing right breast. It was open, and so that is how we choose that code. The next thing that they did was they took out lymph nodes. and they took out axillary lymph nodes, and they were axillary lymph nodes on the right. So lymphatic axillary right, 07B5, and this was open, and it was diagnostic. They tell us that they sent that to pathology. And then we have the fact that they also performed a biopsy of the breast mass. And so that is an excision of the breast. And this was on the right. It was the right breast. And it was open. And it was also diagnostic. So the body part that they were working on was the right breast. First they did an excision to check for cancer. It was positive. Then they did a total mastectomy. They also took out a sentinel lymph node from an axillary lymph node, and it was a single lymph node, so that was also an excision. And so that is how we got those codes. Now, your question for this lecture is, I want you to tell me where in the code is it reflected that the procedure was done with a scope, that it was either laparoscopic or thoracoscopic or arthroscopic. Where in that 7-digit code, which character tells you whether or not a scope was used? And so that is the question for this lecture, and that will conclude this second lecture for Chapter 8.